Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning. Happy Thursday, April 23rd. Thank you for joining us on the Wild Health COVID-19 update. Dr. Jeremy Stitch is sitting in for Mike today.
Hey, thank you, Matt. Let's start with some epidemiology updates in the United States. As of Tuesday evening, the CDC reports 802,583 coronavirus cases and 44,575 deaths in the United States. That represents a 3.4% increase in cases and 6.7% increase in deaths since the previous day. We're expecting a rise, and we're seeing this translated in the evidence. As of this evening, the Worldometer reports 837,719 cases and 46,771 deaths in the United States, and approximately 2.6 million cases and 183,000 deaths worldwide.
And as Jeremy mentioned, we're expecting a rise every day. That's going to continue to happen, but the point is the rate of rises. Now we're seeing this 3.4 and 6.7% increases, which is so much better than the 20 to 30%. So even though we're going to keep reporting bigger numbers, it's not about how big the number is. It's about the rate of rise and the flattening.
Yeah, that's a great point. And in some global updates, we have data from the Financial Times that shows that the daily new coronavirus cases in the United States is continuing to flatten, and the death rate continues to rise. Worldwide, we're seeing increases in severe outbreaks in Brazil, India, Turkey, and Russia. The curve remains noticeably flat in countries that acted relatively early, including Austria, Norway, and Australia. The death rate in Norway is rising more slowly than in its neighbor Sweden, and Sweden, as you know, has come under some recent scrutiny for its notably, quote, soft approach to containing the outbreak. Meanwhile, Singapore and Japan, countries that appeared to have flattened their curves early on, continue to battle these growing outbreaks.
Yeah, we'll continue to watch Sweden and then also Georgia now that they've opened up just to see what happens. They're going to be kind of a nice experiment for the rest of us to see what happens when you don't really lock down or when you open up kind of early. In U.S. news, New York continues to show signs that its outbreak is stabilized. For the third day in a row, daily deaths in New York dropped to below 500. The number of patients hospitalized for coronavirus also continues to decrease, dropping for the 9th day in a row. In his daily briefing today, Governor Cuomo announced that New York will be working with New Jersey and Connecticut to launch an ambitious test and trace program in order to ensure that the outbreak in the tri-state area remains contained. Former New York City Mayor Mike Bloomberg will contribute more than $10 million to the effort and will also be involved in designing the program as well as hiring and training contact tracers. The efforts will be led by Johns Hopkins University and Vital Strategies, a global public health organization. Tracers will be recruited from a pool of 35,000 students in medical fields from local universities. Governor Cuomo explained that this effort will ensure that the state can safely reopen without risking a resurgence of cases. I think this is a really cool project as there is a lot higher unemployment right now, and to be able to use people who may be out of work. Here they talk about medical students from medical fields, so not really unemployed. But just today, Jeremy was having a conversation with Dr. Bright, and we were thinking about scaling up testing and where we're going to get the staffing for that. And a lot of actual hospitals are laying off people. Even our local university is laying off techs. So if we're able to kind of employ people for these tracing jobs, that's going to be great. So hopefully other states and other areas will follow that lead. Meanwhile, other states have forged ahead with easing social distancing restrictions. South Carolina, Georgia, Texas, Tennessee, and Florida will be lifting many restrictions over the next week. None of those states, no state, in fact, has demonstrated a sustained 14-day decrease in cases, which is the recommended benchmark for slowly reopening the state. In fact, cases continue to rise in some of those states, including Texas and Georgia. In an interview with the Washington Post, the director of the CDC warned that resuming public life too soon will result in a second wave of the outbreak that will be significantly more devastating than the first. This is because it will likely coincide with flu season, meaning that the nation's already strained healthcare infrastructure will have to deal with two simultaneous respiratory outbreaks, a task it is not equipped to handle. This is going to be a kind of massive experiment we're seeing here with these states behaving so differently from state to state. So we'll continue reporting on it and let you know what we find. There's some really interesting new websites out there that, for example, report R0 by state. So we'll put a link to that, but those are some really interesting things to follow in real time.
And we have one article to discuss today, somewhat interesting. This one is called The Outcomes in Patients with COVID-19 Infection Taking ACE Inhibitors or ARBs, angiotensin receptor blockers. This was released the 14th, and this is a review article from Current Cardiology Reports. It summarized 19 articles and cohort studies addressing outcomes on these patients who were taking ACE inhibitors and ARBs, who were infected with COVID-19. Now, we've gone over this a little bit before, but this article points out the increasingly obvious data that the patients who have hypertension and diabetes tend to have worse outcomes. There's no surprise there. And they explore the hypothesis that angiotensin II receptors are overexpressed in the respiratory epithelium and could serve as an entry point into the lungs. I found this somewhat interesting because they took a retrospective analysis and the authors reviewed the literature, and they concluded that there was no significant evidence to support an association of ACE inhibitors or ARB use with severity of infection at this time. And they do offer the colloquial common closing statements of findings may change in the pandemic. So no surprises there. What I actually thought was more interesting about this article was that it also states a cohort of 52 critically ill patients revealed cardiac injury in 12% of those. And I thought this was actually a more interesting and compelling component of the article. Why this random number, and where does this 12% of cardiac injury actually come from? As we start to learn more and more about this virus, I actually left this article with more questions than answered, but I'm actually really looking forward to the data that comes out in the next couple weeks. Is this injury, is this a stress cardiac injury? Is this the cardiomyopathy that we've heard reported? Are we seeing strain from multiple microthromboembolic events in the lungs? I think this is just incredibly interesting. And like I said, I actually found that to be one of the more compelling notes. I think the jury is still out on ACE inhibitors and ARBs.
Yeah, I was just having a text conversation with a patient who is pretty young and healthy, and just talking about not really being very at risk with the mortality rate being low and their demographic. And the thing that I pointed out is that there is a significant portion of the population that's going to have chronic lung and cardiac injuries. And that's what I'm worried about for someone kind of as healthy as myself or this patient. And we don't know what that number is yet. It may not be bad, but it may be bad. I think we just need more information on that. Everyone talks about the case fatality rate, the mortality, but the morbidity is also a very interesting and important topic to consider. And since you mentioned ACE inhibitors, I wasn't planning on talking about this article because we will dig in later, but last night Mike and Taylor and I were having a conversation with Chris Mason, and he shared with us a pre-pub study that they're getting ready to submit, which was really fascinating. It was mainly about LAMP testing. That's our main interest, but a really cool thing that we found in it was some data related to ACE inhibitors and mortality. They had a pretty high hazard ratio in patients who were taking ACE inhibitors, correlating with mechanical ventilation need and mortality. Now, obviously, teasing out, was it from the ACE inhibitors or was it from the hypertension? The reason they were taking the ACE inhibitors is hard to do. They say they corrected for factors, but we want to really dig into this article with Chris when we get a chance. We plan to do that in the future because it's hard to really tease those things out in a non-randomized trial. And speaking of non-randomized trial, hope you're okay if I rant for just a second, Jeremy.
Go for it.
Just watching the news, and I've been getting more and more angry and frustrated by the reporting on this study about hydroxychloroquine, the one showing that it, quote unquote, leads to more deaths. So there was a VA study that was published a couple of days ago, and we haven't talked about it because I just want to watch the reporting to see if anyone actually does this justice, and they're just not. So in this study, they looked at, I think it was 368 patients or something like that. It was not a huge number, but a big number, bigger than we've looked at before. And the reporting I just see over and over on every news channel and every article I read is they report it as, let me just read some of the headlines, something like anti-malarial drug Trump touted as a coronavirus cure isn't effective and may lead to more deaths. Those types of things. And I keep hearing even physicians on TV saying, hey, more patients died. And the statistic they keep quoting is they say about 28% of patients who were given hydroxychloroquine plus usual care died, and only 11% of those getting routine care alone died. So that's a massive difference, right? Over twice as many people dying, like hydroxychloroquine is killing patients, and that's how they're reporting it. And I just think this is just dangerous and infuriating. So when I hear the president a month ago talking about hydroxychloroquine and how it could be a magic pill and really a savior, I thought that was horrible. That's not what the science was saying. But then when I hear people on the other side saying, look what Trump's doing, this is killing people, that's also not the case. You have to be able to interpret these studies and read them a little better. So when you look at this study, so if you think about this, when these patients are coming in, this is a non-randomized, non-controlled trial. This is not even really a study. This is just a report. Someone's just giving you some statistics. So consider who of this patient cohort got hydroxychloroquine. It's not a treatment that is standard. So if you're getting the medicine, it's probably because the doctor taking care of you is really worried. So you're probably much sicker. So that is probably the most likely explanation for why these patients are dying more frequently. Now, in the study, when you read it, they do say that the risk of overall mortality in the hydroxychloroquine alone group persisted after adjusting for the propensity of being treated with a drug. But they don't really tell how. They don't give any data. They don't say anything else about this. And it's simply not possible to completely adjust for confounding factors. So I'm kind of glad this was published because it, I think, is scaring a lot of people away from taking this until we have real science. So it's not a bad thing that it was published, but I don't want people to panic and think that hydroxychloroquine is killing people as well. We need actual good science. We need to stop depending on these reports of looking at small groups or what happened in a group with all these confounding factors, and we need to wait for the real evidence. And I think I understand why this group reported this. They reported it just to kind of have people hold on a second. And hopefully they reported this for a good reason, that they want to actually show that we do need to wait for good science. But the reporting on it has just been atrocious. So I would encourage people just to be very wary of what they hear on the news. And as hard as it is, we're going to have to be patient. There are several randomized controlled trials going on of hydroxychloroquine for COVID-19. It may help and it may not. But until we have those trials, these quote-unquote reports are wasting our time and are a distraction. So sorry for that little bit of a rant. We will cover more studies when they come out, hopefully good studies and fewer reports. And tomorrow we're going to be publishing a podcast on return to work, return to play. We had a town hall webinar where we discussed this for quite a long time, operating characteristics of serology test, antibody test, how to apply antibody tests versus coronavirus viral test, all the different types of testing, which ones are important in what circumstances. how to come up with a framework for thinking about returning to work and returning to play. Hopefully you'll find it informative. That's going to be published tomorrow. And as we continue to develop protocols, we'll continue to push those out. We want to share all the information that we can and that we're coming up with. Thanks for listening.
Yeah, thanks, Matt. I always appreciate listening to your rants. That's actually a really good one, though. Thank you guys for tuning in. Have a great night.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.